Thank you, everyone. Thank you, Mark, Sandy, for sharing your story to give us smiles too. That's very important, and to highlight the nature of a community, of not being alone, guys. It's a before and after. That's one thing. So, are you guys ready? Let's take the caps lock out. There is a CC. Here, this guy. There could be a frozen. Oh, frozen. Oh, I don't know. These interfaces. We're trying to do Zoom and screen. So I'm going to try to walk you through. So prepare for something we've done in webinars online as we were advancing the knowledge about cerebrovascular disease. I'm very thankful to Dr. Murdoch and Dr. Lindsay that has already started the mechanistic side and why vessels have a problem in this disease. And then there's going to be like a little bit of a neuroanatomy 101, and then stroke 101, and then neurology 101, and then critical care 101. But the idea is that you have a resource here, and you can watch it again, you can rewind, fast forward. So I'll try to go through these slides, and the content of the slides have didactic stuff that are coming from textbooks, and then also the work that we've done together a few years ago with 27 patients that have MSMDS caused by arginine 179. It was published in Neurology, and it helps us today to understand that some of the complications in the brain can be predicted by how we see the vasculature and certain features in the imaging of the brain. So before I go too far, this is the disclaimer I was talking about, and I'll just have it here so it's recorded somewhere. Just remember, we are trying to learn together, but this is not medical advice. Those are my disclosures. I never get to update them. There's two other, NIH is funding big part of this. So there are 3 other ones, you have a comma, there are 2 more that I didn't add. And then I am heavily involved in gene therapy for rare diseases. I'm part of this thing here at MGH. That is a center for rare neurological conditions, and we have 7 clinical trials in gene therapy and other therapies for rare conditions. And they're communities that are smaller than yours and bigger than yours. So just to give you a sense that can be done. And the luxury of being in a hospital that, just by chance, has a pediatric hospital inside a general hospital. It's like a lot of the hospitals that we have in the country. And it gives us the possibility of seeing, understanding, and study the lifespan completely from the baby time until you are a senior person. So these are what we are going to try to cover. We're going to try to learn about stroke and the forms of vascular disease. We're going to review different vessels and how they're affected in this particular disease. I'm going to reference everything to arginine 179, and I know in the room there might be people not with these exact variants. So what you're seeing here, if you're not on arginine 179 or 258, which are the 2 most common to have the severe forms of the cerebrovascular disease, I'll recommend that you take everything with a lot of caution and remembering that you may not have nothing to do with this, okay? There are other mutations, the majority of them, that are not in arginine 179 and 258 that cause primarily aortic disease. And I wanna put a shout out to the Ritter Foundation, the Montalcino Consortium for Aorta, because that community has done the longest and the best work, both advocacy, research, and therapeutic development. So if you're not in this group of more brain involvement, just remember that, and there are other resources that might be more applicable to your condition. We're going to talk quite a bit on preventive and rehabilitation strategies. I will talk even from acute management, and then questions and answers at the end of the session after Dr. Joseph Rizzo, our neuro-ophthalmologist that has taken us on MSMDS, is going to talk about the eye, with then open to questions and answers. So I'm thrilled to be back here with you guys in person together. And this was the meeting in 2019, and these are the families back then, and you guys made it. You just more than doubled it. So good job at the foundation and the advocacy group, as the families and everybody putting efforts and supporting, coming here, including the scientists and the different groups that are working on this. So a very quick review. Remember, it's autosomal dominant. We don't talk about this because the majority of the patients affected are de novo, means only that patient is affected. But whenever you diagnose someone with an ACTA2 mutation, the parents should be tested, guys. Don't forget that. We do have a couple of families that have had an affected child from an affected mother, for example. So, and as we get better with clinical management, we will get to the point where our adults, and there are several ones, are starting to plan a family. So we're going to have to be able to guide them. And not just talking about genetic counseling, but if a pregnancy is being contemplated, is there anything that we need to do differently? How do we connect them with the right care? But autosomal dominant, but mostly de novo. I'm going to talk about mostly the 179s. I emphasize this, that can be diagnosed at birth. And over and over and over, we hear the story of they went for the surgery for the PDA. We talked a lot about it, or aortopulmonary window. And then when they came back from anesthesia, someone noticed the pupils were large and non-dilated, and they had to rush the kid to the CT scanner because they thought something was happening in the brain, that the kid had a bleed or something. When the babies are discharged from the hospital, when we shine a light, which is mandatory newborn screening, we were also checking a box for, does your pupil constrict? We could diagnose these patients right there. So if you want another torch, some of you should take on newborn screening modification, because just by adding that check, okay, which is done in every single newborn in the United States and Europe, that could increase the yield of diagnosing and finding these patients before they're before they diagnose the PDA or anything else. So I'm going to put a shout for this. Has happened in other diseases, takes years to get it approved. It requires the patients, and there is no other way to do it. So we know that in general, the strokes occur after the kids start walking. I'm talking about the large arterial ischemic strokes, not the white matter injury, and I'll give you a little bit of that. We know aortic dissections follow in the second decade of life, and either the dissection or the replacement. And that's beautifully described in that paper that Dr. Murdoch was referring, in the Regalado paper, famous first retrospective natural history study that says what happens in the disease. And surgical and medical cannot prevent the strokes. And I put the conclusion kind of at the top because we're still studying this. And in fact, there is Angela Cass, one of the family advocates and mother of a patient affected with MSMDS, has launched getting us all to work together. I'm talking about neurosurgeons across the whole globe to see if we can really answer that question. Does the surgery helps the revascularization for strokes? And I'll say a little bit more later on. So we know that without therapy, we get vessels to narrow in the brain. And at the same time, don't forget, this is a normal vessel angiogram, catheter angiogram of the brain. And this is the patient 5-year-old, both of them. And this is a 5-year-old with this particular condition, the arginine 179. And you can see how while the carotid, the one that is in the neck, and it comes into the brain, is dilated, straightened, then the vessels in the brain are narrow, you can see, and they're missing the tortuosity. This is so characteristic that with this angiogram, either an MRI in CT or in catheter angiogram, with this pattern, you can make the diagnosis. There are several patients that we've known got diagnosed genetically after they have an MRI of the brain. So we're gonna, we have her here, the one that did this work, Jane Altman. I'm gonna ask you to raise your hand over there in the back. So she basically modeled in silico the interactions of the protein that we know is altered is alpha smooth muscle actin isotype 2, that's ACTA2 or ACTA2. And this is a molecule of that protein. That's the other molecule of the same protein. They need to interact with each other to make a chain. And this is what happens if you change that arginine here in 179 for a histidine. And this is an in silico modeling of something that already the group in Texas have shown that was the most likely pathomechanism. And what this group did in Tel Aviv is go ahead and screen in this in silico model all the FDA-approved drugs, and some of the work that came from that. You just saw Ahmed talking about the effects over the gut and the survival and the exercise for the mouse model. So if the ACTA2, these round things here, are not able to make chains, they cannot do those rods that make what we call the scaffold of a cell, in this case, the smooth muscle cells, and that's the cytoskeleton. If they cannot form the fibrils, and call it thin filaments, they cannot roll against each other, the cell cannot contract. And if you cannot contract, there's a lot of things that happen. Among them, they make more of themselves. And when they make more of themselves, that's called proliferation. We also heard about migration being increased. And that if it happens in the vessel lumen, it can lead to narrowing of that vessel. So I just went back to this because when I started showing pictures of the MRIs, you're gonna see thin vessels, and I'm gonna keep going back to the narrowing, which is very important if we could prevent it. I was gonna put this at the end. I was asked to mention and talk about dysautonomia. And what is dysautonomia? And I always start with this as a demonstration that the disease is happening in every part of the body that have a smooth muscle, okay? And that we have symptoms pretty much in every organ that depends on a smooth muscle. And not only that, these organs is not the kind of organ that you control, like I'm gonna move my colon right now, and then I move it. You just have it kind of in automatic mode, and it's in an equilibrium, but it is controlled with the brain. And is that connection with the brain that is not a voluntary type of control, but more an automatic type of control, is called autonomic nervous system. And it happens that the smooth muscle cells, wherever they are, and you heard Ahmed talking about the gut, and the neurons coming to the gut, and I was like, what is he talking about? Every single organ that has a smooth muscles is innervated, nerve cells get there, by this system, the autonomic nervous system. So when you hear the word dysautonomia, to me, it's not surprising at all, because I may have even the connections, but if the guys that have to do the work are dysfunctional, they're not contracting, they're not moving, then I will have symptoms from those organs. And they could look like autonomic dysfunction. So like this fine-tuned system is not really working. So beyond the classic symptoms that we talk about in the eye and everything, the autonomic system usually has two kind of divisions. These are very arbitrary, but pretty practical to think about it. Most practical because we use drugs to make this faster or slower, make this faster or slower. So that's why it's very practical, because it's managed and coordinated by different type of receptors, and different drugs are used for the different parts. But basically you have a parasympathetic and a sympathetic system. I was like, oh, this is starting to get very complicated. You guys know about lions, and if a lion starts running towards you, you're gonna run. So if you get to run, you're gonna get heart rate to go up. You're gonna start breathing much more open, so you had to relax your airway to get more air. Your heart rate is gonna go up. Your blood pressure is the blood flow is gonna go away from the gut, and you're not gonna start digesting your lunch. If the lion is running, we need all the blood in the legs, so we constrict the vessels in the gut, and then open it up in the skeletal muscle. And again, I'm gonna start peeing, so I do that when I'm chill, but I have to relax my bladder so I can continue to filter, and et cetera, et cetera. So you guys get the gist. The eyes is very easy. If a lion runs after me, I'm gonna see more, so I open my pupils. That's usually the analogy that I use. So dilatation of the eye is sympathetic system. Give you an example of something that is an agonist of this system, stimulants. Anyone that is on stimulants can have larger pupils, okay? The other one is after the lion ran after, and I saved myself, and I then ate my lunch, and I'm taking a nap. That's the parasympathetic. But just to put it simple, even when the lion is running after me, I have a parasympathetic system trying to control this thing. It's a balance. It's a constant balance at play. And they have connections with the brain that are organized in different ways, and some come more from, we call it the cranial nerves and the sacral area of the spinal cord, and the other ones come from the thoracic spine. beautiful anatomy, well described, well understood. We treat this system all the time when we have a patient sick in the ICU because we take over these systems just to get the patients stabilized. Another thing to remember is that alpha smooth muscle actin is expressed in the vessels, okay, of all sizes, okay? So large arteries, muscular arteries, arterioles, the capillaries, this is how the vascular system works. And then is even expressed lower amount, but still expressed in the venous system. And we do have some patients that have venous insufficiency type of symptoms. And we do also start seeing some lymphatic system that is not working as well as they become bigger and older and grow. So these are symptoms of autonomic dysfunction, okay? And there is a Dysautonomia project. You can participate, give things of your data and your symptoms, but basically the things that we were talking about, the pupillary response, neurologically, dysautonomia is a difficult one to diagnose. So if you read about migraine, cognitive deficit, brain fog, mental clouding, quite a mysterious animal. So it's much easier to diagnose dysautonomia if I am looking at the cardiovascular system. Why? When we go from lying down to standing, just to give you an example, we also have to adjust our heart rate and our vessels have to constrict because we go from towards gravity with the head down to up against gravity. We need to get blood flow very quickly into the brain. So we squeeze vessels in the body to get blood flow to the head. And on top of that, we increase maybe a little bit our heart rate to get the blood flow that we need by increasing the cardiac output to the head. When patients have dysautonomia, either because their nerves are not working or their smooth muscle in the arteries is not working. When you get from like being lying flat to standing, you can't squeeze that quickly, okay? Or you can squeeze only a little bit. The rest is done with the heart. So you get tachycardia. So we increase the heart rate so you can keep pumping more blood flow to the head. If not, you'll start feeling lightheaded, okay? And like you're gonna pass out, like syncope. And that has a name in this autonomia world. We call it POTS, paroxysmal orthostatic tachycardia. And it's something that we found in 100% of all MSMDS patients that were ever studied. So we know, and it's not surprising, because the vessels need to be able to constrict very quickly, and we just talked about the smooth muscle cells not being able to do the work of contracting that efficiently. So, and what does it mean? It means that some of these symptoms that you have sometimes are that there is little these adjustments that can start making you have the feeling that you're unwell, and migraines, we consider them part of that. And the other things is like nausea, vomiting, diarrhea, abdominal distension. Those things are also signs of dysautonomia. If you just read those boxes, it's the symptoms that we see in the patients with MSMDS. So, and is it the nervous system or is it the end organ that the nervous system has to act on, which is the smooth muscle base that is dysfunctional? I would say 80% is the smooth muscle. Maybe there is a 20% because these babies have developed with a different smooth muscle. And it's possible that the nerve fibers, they're teeny tiny thin fibers for the system, are not completely sprouted. Ahmed touched a little bit on this when he was talking about the gut. That test where he was putting acetylcholine, which is a system for the hormone for the parasympathetic system, did not make the smooth muscle move at all. So we know that there may be a little bit of a problem with nerve cells as well. So let's go now back into other symptoms. And I always say, this is a real reason for everything we do, and it must get done, okay? I don't want excuses. So these are the patients that are here in this meeting. Thank you, Dixie, for sending down. So these were the consequences, the neurological symptoms we know that can occur in MSMDS because you have had a stroke, because you had seizures, because you are developing with difficulties. Like we just heard, every single patient is in the hospital. These kids have had open heart surgery. Some of them have been months at a time, if not years, in the hospital. So all of that has an impact in your development when you're not able to experience the world like other kids that are outside or playing, or babies that are with their families. This thing called cerebral palsy, I'm gonna bunk it because Dr. Wishart, which is over there, is gonna tell us a lot more about rehabilitation. But basically, it's a term that is used for anyone that has difficulty with muscle tone and lower extremities by the age of 2. It's a kind of consensus. So it includes anyone that has had a stroke or any injury in the brain that gives you difficulty with your muscles in your legs. That's the simplest way to put cerebral palsy. We see problems with balance and steadiness, behavioral problems, concentration, and memory. And I'm going to go a little bit more extensively into this. Okay. So other neurological symptoms, and this is what I'm talking about here, is all that we learned from the work that we did with Diana Milowicz and Ellen Regalado. And these were the other neurological complaints that were collected from the medical records. I particularly have not seen the Meniere, and I'm pretty consistently thinking this probably is dysautonomia or cerebellar dysfunction. But anything else, we've seen everything. And in fact, the intolerance to cold, for example, another sign of dysautonomia. If I cannot get my little vessels in the skin to redistribute the flow when it's cold, then I really feel that I'm cold. And in fact, a very simple measure to change it is to put a little sheet of something that covers you from spilling the heat that your body is creating, like running clothing type of thing, breathable running stuff. That just a little thin layer could maintain the heat towards your body and make your feeling of being cold much less and be more tolerant. I'm going to admit someone here. I have someone in Zoom that wants to be admitted. So since then, and thank you to the work that was done by the families in the Young Genetic Stroke Alliance, that's a nonprofit that I have founded for families like you. When you're just starting, don't have a foundation yourself, you can come work with us. Rebecca coaches everybody how to get your own group advocacy group. And then you can move into your own advocacy group. And this is work that we've done with the collaboration of the families, working with YGSA, the Young Genetic Stroke Alliance, into asking, and many of you have been the respondents of this, to 37 patients with RGD-179. And I shout to Anna Lynch, she's in the back. She kind of wrapped up this work, is about to get out. And we just know now that the incidence, as reported by the patients, of a stroke is higher than what we saw in the medical records. And this is, again, to emphasize how you guys need to be at the center stage of anything that is done and any research. We learned so much in this survey, covers all the system, not just the brain, that it helped us design the natural history study and what parameters we need to be following and monitoring the patients for to capture the burden of the disease, what matters the most to the patients. We also saw the incidence of seizures was higher, and interestingly enough, they are not only related to stroke. It's not in kids that have had a stroke that have seizures. Some kids have had seizures that have not had a stroke. And when we ask very superficially, but it's dividing fine motor, gross motor, walking, age-appropriate social interactions, intellectual abilities, pretty much anywhere from 50 to 80% of patients have noticed a developmental delay. So, and this was only reported as like 15% of the patients have developmental delays. I would say not the case. And it's my experience when I meet these patients that they are struggling with things. And why do I put this out? We need the services. We need to understand this. We need to support them. They can learn if we help them with how to do that learning with their own challenges. And one of them is also developing the ability to walk. And that's a very useful one when you're thinking about meaningful outcomes on a clinical trial, because it can take you a long way if you can improve the ability to exercise, to walk, and ambulate. So what about the brain? And we're gonna try to do anatomy here. So bear with me. My students in the university, I usually ask them to draw on a paper. What do you know about the central nervous system? And you can see these things by Harvard students. So it's not so promising, guys. So they're undergrads, many of them. They haven't had neuroscience. But when you think about the brain and the nervous system, blah, 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 we always divide it in two at minimum. A central, inside the bony parts, the spine, the spinal cord, and the skull, the brain, and the peripheral, all the nerves. This thing, the brain inside the head and the spinal cord are blood supply directly, almost in line with the heart. The heart will be here, it's in the aorta, carotid, coming up to the brain, and then from the subclavian arteries, which is another branch of the aorta, you supply with the vertebral arteries, the back part of the brain. So we have a posterior circulation and anterior circulation, important for anyone that is having symptoms, because the symptoms are different depending what part of the brain is affected, and that tells you what vessel may be giving you the trouble and how to direct the assessments and the management. The brain, looking from the bottom of the brain, you can see that there is this thing that is kind of continuing with the spinal cord, that's the brainstem. The upper part is called the cerebrum, and we call it cerebral hemispheres, the right and the left. And we have frontal lobe, what sits in front of the front part of the brain, the temporal lobe, and in the back, we call it the occipital lobe. I use, since we had a broccoli something earlier, I was like, really, broccoli? So I use the broccoli brain as a very good analogy. I usually ask people when they're in my clinic to think about a tree, because everybody has 3 dimensions of a tree. Everybody has seen a tree. I don't have to explain you, this is above, this is below. You know what a tree is. So imagine the canopy of a tree, or broccoli here, as the cerebrum. The stem of the tree is the brain stem. The main root of that tree will be the spinal cord. And from the main root arise all the small roots, which are the nerve roots. And we had this guy here, which I usually use the analogy of a backpack. And I do that because it's attached to the stem with the straps of white matter. So that's the cerebellum, and that is used to servo assist the cerebrum, the spinal cord, and everything. It's kind of a big coordinator, if you want. One thing to remember, and this is not longer we think is like this, now we have tools to really demonstrate that in humans, in patients, in vivo, by imaging. The brain doesn't work in isolation. Nothing happens in isolation. And it doesn't happen just inside the head. You need a connection with the body and with the environment through all the senses that the brain is connected with. And it processes all that information in a network. And everybody has some sort of social media. So you understand very well what is to be a hub that has 1,000 views versus one that has 3 million versus one that has 3. So I use that because if you take down a hub that has a lot of connections, you have more symptoms, and we call those usually eloquent cortices. And if you take a hub on something that has more alternatives but less density of connections across that particular point, you end up with different, more subtle symptoms, which are more difficult to localize, to say, oh, that's what not working. And if you look at here, this is a connectome. So basically brain MRI images can give you this beautiful green means from front to back direction of fibers, red means from right to left, and blue means from up to down. And you can see how the connections of the neurons, the axons, are being picked up by this imaging here. The brain has a place for everything. This is the old-fashioned neuroanatomy. There is an area of the brain in the frontal lobe that is on charge of moving stuff, one in the parietal lobe that is in charge of receiving all the touch and the sensory information from the joints and the muscles. There is a part of the brain that is in charge of seeing, which is the visual cortex, a part of the brain that is in charge of hearing and tasting and so on. And what about thinking, when am I gonna pay my bills? Good luck. That's in both sides of the brain, in the frontal lobe, connections with everything, memory circuits. It's a much more complex thing. Therefore, when you have injury here, it's more complicated to see what really is not working. And you may be forgetting stuff and not being able to pay your bills. I told you the brain has a map for everything. It's truly a map of the body. And here you have sensory, and here you have motor. And if I just look at those cortex in the frontal and parietal lobe, and you slice and you just map, that's how this looks like. And if I give you a 3D representation of that, it will look like this. And it's like, wait a second, like, why do you have so much hand? Because we have a lot of dexterity in our hands, so a lot of connections for these muscles. Well, I don't have much on my trunk, like I don't do too many precise things. So one neuron innervates a lot of muscle, while in the eye, one neuron innervates one fiber of muscle. And Dr. Rizzo always explains to us, is like, it takes very little and you can see it with the extraocular movement. You start seeing double because the muscle becomes much more affected because there are more density of neurons. What are these neurons things that we're talking about? Those are the real cells that do the job, and they're connected through their axons and their dendrites. And the axons need this insulation, like any cable that conducts electricity will need an insulation, and that's called myelin, and it's made by another type of cells, which are called oligodendrocytes. This is important because in MSMDS, we have the gray matter, where the neurons live, and the white matter affected. The gray matter gets affected if you get a stroke. The white matter can get affected by a different type of stroke. It's ischemia on the deep parts of the brain, which is where the connections are. So different cells, different problem, different symptoms, different treatment. So the brain for the motor system goes from up to down. It's a pretty simple one. 2 neurons, one up there, one in the spinal cord, wherever you need to get. So if you are going to the quads, you're going to be here in the low thoracic upper lumbar, and then you will connect the brain with the other side of the body. If this neuron in a stroke gets affected, you will lose the ability to contact with this neuron, and therefore will have weakness or not being able to move the way that you want that particular muscle. Importantly, this muscle is under also the control of this reflex. So there is a feedback loop to keep the muscle tone so you're not flaccid. And when you don't have the commander, then these guys are under no control, and they keep going and going and going, and that's a spasticity. That's why they get stiff, because the spinal reflexes are released while the upper motor neuron is injured. And the sensory system is the other way around. It goes from wherever the sensory receptors are, in this case the hand, all the way in the spinal cord. They cross and they go up to the brain, and they connect to the sensory area of the brain. The brain has a map for everything. So every root of the spinal cord matches to a place. So when I usually shouldn't do the middle finger because that's not good. This is C6, cervical 6 level, for example, and this is C8. And so when we do a neuro exam, I might touch and I put things, I can map if there is a deficit, where exactly in the nervous system we have that defect or that problem. When you want to talk, first of all, you need to decode sound, and that's what we call the Wernicke area. And then you need to connect to this part that is called the Broca area. There is a lot of Europeans, neuroanatomists that name everything in the brain, so we have a name for everything with one of these guys. And basically, this circuit is the most basic part of language. So a stroke that affects this area could give you difficulty comprehending, but you can still be talking with fluency, but not making much sense. Stroke in this area could give you the ability to comprehend. You can raise your hand, and then when you want to talk and repeat something, today is a sunny day in Boston, you can't do it. Difficulties with the speech. So we can basically interrogate the brain with a neurological exam. The visual system is a lot more complicated, and I'll put a shout out to our pediatric stroke educational series, because there is a lot of materials there by a lot of experts that could be helpful in understanding this. But a lot of our patients have central, cortical, and auditory visual processing issues because of the white matter. So the connections between the eye and the back of the brain go through those white matter tracks. And when you have white matter injury in these parts of the brain, these, instead of highways, could be small roads. And if that's happening, you have a slow processing. Doesn't mean you cannot see it, doesn't mean you cannot learn it, doesn't mean you cannot use it, just slower. Which means that when we are trying to teach and interact with them, we need to give them more time. Or give them, maybe, instead of just something visual, something with more contrast, something with the sound, so they can use another modality to supplement that learning. So, and these things that are very well studied by therapists. I'm gonna fly through this. The cerebellum, if you wanna think about it, how is it that it works? You just need to take alcohol. And that's what give you all the cerebellar symptoms, okay? Cerebellum is there to really fine balance everything. And is coordinating information from the sight, information from apparatus in the head called vestibular system, and the information from the spinal cord that is coming with those sensory neurons that we were talking about. All these three are necessary for you to do things with precision and have balance. So another word is, and you saw it says cognitive. The cerebellum is not just motor. it assists the cognitive function. So if your kid has got a cerebellar stroke, there may be issues with that. And finally, the tree house of that tree is this called thing, basal ganglia and thalamus. And if these structures are affected, it's very much expected that you have troubles with muscle tone and behavior and mood. So if these areas were affected, you may have different type of problems. So the vasculature in here, the broccoli brain again, this is the vascular system. Why are the patients having this white matter injury in MSMDS? And we're going to move to the concrete recommendations in the next part of the talk. As you know, when the babies are in the belly, inside the mother's uterus, they have the placenta. The mom is doing all the oxygenation and blood flow to the head, and that vein, the umbilical vein, will bring the blood flow into the heart. And there is a connection that is meant to be there, and there is another connection, the PDA and the PFOs, that are, or foraminal valley, that are there to really allow the best blood flow to get to the head first. Why? Because sending it to the lungs doesn't make sense. The baby is not breathing air, so it's not oxygenating. When you're being born, you have to separate from this system. You have to take a breath, and these lungs will change the pressures, and that's the time where your whole blood pressure and circulation will change dramatically. And we think this is the most likely time where we're seeing white matter injury in many of the patients. And we do have evidence in 11 babies where we had imaging acutely right after birth that we know there is already acute white matter injury happening then. And I'm going to say this because the one other thing that we learned is that the white matter injury is not progressive. And I'm kind of running ahead of myself. There is also veins in the brain. I'm going to leave them to the side, but there's something called venous sinus thrombosis. So what type of strokes can one have? And this is important, and then we'll concentrate on what type of strokes MSMDS can have. So there are arterial ischemic strokes, and the most common type, when you think about the elder, is a clot that comes either from a vessel or a clot that forms in that particular artery, or a clot that comes from the heart and goes and occludes an artery, and it gives you an area of the brain that stops getting blood flow. And we call that the core of the injury. And then there is an area of the brain that it kind of gets a little bit of blood flow from the other branches. We call that the penumbra, or the tissue at risk. So all our treatments in acute stroke are to reopen that vessel, so we can only deal with the core of the injury, but not with the rest of the territory at risk. So we are all working to salvage that territory that, if I don't open the vessel, will go down and could be lost. So for these clots are usually made of thrombin and platelets. That's what that little picture means. In MSMDS, in arginine 179, and going back to what we discussed this morning, the mechanism of stroke is different. And this is very important because the treatment has to be different. These vessels are narrowed because of those smooth muscle cells that decided to make more of themselves and move into the lumen and narrow the effective blood flow. And because these vessels are narrow, if I change your blood pressure and I make you hypotensive, or I change your oxygen because you have a PDA or an AP window and you're hypoxic, then you put the parts of the brain that are the connections, the white matter, at highest risk. We call this border zone or watershed ischemia or stroke. So the white matter in ACTA-2, to our best understanding today, is an event-related white matter injury. It's not the same as other white matter disorders where it's progressive, okay? Where just it doesn't stop, keeps going and going and going. And this is the knowledge we have to date. Could it be different when these kids start going into adulthood and we start studying them? Yes, but to the moment, we haven't seen this white matter injury going further. There is another type of stroke, which is, let me just go through this one. Skip this. Clots in the brain we haven't seen in MSMDS, so in the venous system, so that's just to say. And there's another type of stroke which is hemorrhagic, so a vessel ruptures, and then you have blood literally coming into the brain. That we have not seen in MSMDS, and that's important because when you're discussing with your doctors, can I put in a blood thinner? Is there any extra risk of having hemorrhage? The answer is we haven't seen any hemorrhages on these patients. So it's pretty safe to put them on blood thinners, and the management should be driven by the recommendations we currently have for a stroke. This is if you take an MRI, and I put it here just so you guys know what you're looking at, but tilt the broccoli vein, this is the head of the patient, and then if you slice it this way, you see the MRI pictures. And when they show you an acute stroke, this is in the territory of the middle cerebral artery, and you can see here in white, that's the tissue at risk. And this is a very good representation of what it looks like a year later. Okay, so as you can see, not the entire tissue at risk ended up being damaged. The damage is much smaller. We still don't know why some patients do a small damage versus large damage after the exact same type of stroke. And this is the good news to me. There are so many factors that play into the outcome of a stroke. So you never lose hope. Is when you start working with a stroke patient, you never give up, because in children, and I have probably 20 years of experience and seen now my own adults, babies that I receive and graduated them to college, you can never tell how they can do from the acute pictures in the MRI. And we have a lot of research going on that to see if we can help predict who's at risk of what. So in MSMDS, you remember this picture. This is the MSMDS 5-year-old, and this is a control with the vessels, how they usually look like. And I wanted just to put a little mention here, to the fact that we do have human tissue. This is the Munot paper, also working with Diana Milowick's group in UCL, that show that those vessels in the brain, these are meningeal arteries, are also narrow and stenosed. Again, to the emphasis of trying to prevent the narrowing could go a very long way. We have Lauren in the room. I'm gonna have to go through this, and I want in the questions and answer to tell us your experience, but she kindly has provided one of the patients that I have been involved with, and that's Rini, and Rini is here in the center of the picture, and her family. And this is Rini, and this is the part that is difficult to kind of remember, which is before a stroke, these kids can do a lot of things, and I don't know if the sound can play. Is there any way we can get sound? No? Okay. She's singing Frozen. Okay, and Lauren can tell you a lot more. Rini right now is admitted to the Lander 6 shiny building behind us, neuro ICU, to get reevaluated after having suffered several strokes. So when these kids are being born, the vessels in the brain are different, but they're not critically narrowed. As they grow, this is 7 years of age, this is 10 days of life, the arteries that are elastic dilate, then the arteries that are muscular constrict. And when this ratio gets critical, that's when we start seeing the strokes, the territories of the brain that start getting blood flow issues. And that happened to Rini. She started to have strokes, and she got the first one, she got an TIA, she got the second one, and they're still small. And the attempt was, let's try to do revascularization surgery. Smile for Daddy. She gets through the surgery really well, wakes up totally fine. And then around 30 hours after that, she starts having strokes. It's the complete unexpected course of that surgery. It was in the hands of one of the best neurosurgeons in Moya Moya, DC. So very experienced people can have bad outcomes with this disease. And we are going to do everything we can to try to learn about everyone that has been treated with this, to see if they benefited and how, and if there is anything different that is being done, like the anesthesia that may be happening during the procedure, or what happens after the patient is treated. This is very important, and back to your power. Before Rini was diagnosed, more or less in the time that she was being diagnosed, the disease wasn't known, wasn't published yet. Diana was putting this in the map just at that time. And after she's been diagnosed, there's been in 4 years, 26 patients. And this speaks to the fact that the more we know, the more we talk, the more you guys connect and help families get to diagnosis, and the more physicians and researchers put papers out for people and physicians to find what that patient that they have could be mapping to, the more patients are out there. So just exponential. The other one was like 20 years of research. This is 4 years, guys. The power of the community is really to be kept in mind. Does this narrowing of the vessels progress? The answer is Yes, not in every single patient. You have patients here that don't have progression. Okay, this is why natural history are necessary. If I start treating a patient that behaves like this, I'm going to attribute to the drug an effect that in reality doesn't have. It's just the patient that is not doing narrowing. But if I treat a patient like this that is going really aggressively narrowing the vessels, and maybe the drug doesn't have an effect, and if I treat all of those patients, maybe I'm never going to see an effect of the drug because it may not be strong enough. And that's the heterogeneity between the patients that we study, and this is 27 patients in that study, is very important to understand. One thing that was very novel and good to know is this ratio that I was talking about. And if you're going to have a stroke, you usually have more than 80% stenosis in between these two parts of the carotid. If you have less than that, you usually have not had any arterial ischemic strokes. This is only seen in MSMDS. That does not occur in control patients that have had a stroke but don't have MSMDS. So it's a very unique marker of the disease. It's something that we can target. So this is one of the most important slides, and I will work with any of the kids, adults, and anything to get them to drink. Okay, and why? Because at the moment, avoiding dehydration and hypotension is the main measure to prevent stroke, and it's not a minor thing. Okay, this keeps the kids from going into the hospital, from having also symptoms of dysautonomia. So what we were talking about, that's why I didn't cover the management of dysautonomia, is the same as the management for an steno-occlusive arteriopathy. Hydration, hydration, hydration. We put these kids always in antithrombotic therapy. I always put in a caution, make sure that you check all the boxes, that there is no increased risk of bleeding. I avoid iatrogenic hypotension. This is doctors making blood pressure go low. I have migraines. What can I take? Why don't you take a triptan? Why don't you take a amitriptyline? These drugs have vasoactive effects. You run every drug that is given to your child by the neurologist, ideally a stroke one, because you need to clear it. That is not going to get you into trouble. Avoid sedation, and we will have a talk about anesthesia and what things we've been learning. But the main point here is neurons that fire, the ones that are awake, are the ones that call the blood flow. When you put the neurons to sleep in anesthesia, there is less blood flow in everyone. In MSMDS, maybe critically low, and that can cause strokes. And that's why we're trying to optimize this and put in a working group, trying to get guidelines for the families. Avoid hypoxia. This is very relative. You just have heard there are people living up at 2,200 meters of height, and it's totally fine. Your body adapts. What I'm concerned about is a ski trip or a training or something, and then suddenly the gondola doesn't work. They end up at 10,000 feet. One of my patients carries a little canister of oxygen. That if you do that, it will dilate the vessels. You can get down safely. There's always a way. So I'm trying to say, work around life with life. Don't go against it. And we have to focus on quality of life. So this patient of mine is a mogul skier and loves skiing. And the parents have decided it's a risk they want to take. So pregnancy and postpartum should be very carefully managed. We have now experienced one family in particular that have had a child. It was also affected. Headache management is very challenging for the reasons that I was saying. The medications that we usually use can have other effects that we don't want, but we have a list of things that we want you to avoid just in case. And there are other devices that are coming. What do we do when this acute stroke is happening? And many of you in the room have been here, okay? These are the signs, and this is a classic adult slide. These are the most common symptoms in younger children, guys. It's hard to get these symptoms when you are less than 2 or 3 years of age, almost never. Okay, you get seizures, you get change in awareness or lethargy, behavioral change, but sudden behavioral change, all of a sudden, and severe headaches. Those are more common in younger kids with a stroke. We say thumb is brain, so you want to open that vessel, and there's a medication that we use, FDA approved, which is TPA, the thrombolysis, or we put a catheter and go and very courageously take the clot out of the brain. We do this every day. There's 14 patients being treated across every single 24 hours with these therapies that don't have MSMDS, okay? If you put a catheter in the arteries that I show you, the risk of dissection is really high. We don't put catheters in these patients. And I'd also try to show you the type of stroke and the cause of stroke is narrowing of the vessel. It's not a clot. We're not going to be able to take out what is causing the stroke. So we're now giving these patients this treatment. And I want to say it because people may feel they didn't treat me with the standard of care. And they are not treating you with the standard of care for other reasons, hopefully. If not, they're putting your child at risk. And that's something that should be discussed with the person that knows your patient, your child best, or yourself best, and that hopefully is a stroke neurologist. Same things apply in the acute, and this is what we usually do. We put them on fluids, we give them boluses, we put the head down, feet up. You can do that at home, or as you're traveling. Minimize crying and hyperventilation because it constricts the vessels and decreases the blood flow to the brain. So we sometimes give them morphine. And it's like, why are you giving morphine to the kid? He's not complaining about too much pain. Because I don't want to afford having to have a severe crisis of pain. Because if they cry really hard, they're hyperventilating. They're going to start getting dizzy. They can prevent blood flow coming to the head. So we have a lot of little things. They sound very little. They're very important to keep the brain healthy and to minimize the effects of that particular event. And then basically, there's a recommendation to avoid TPA. So if you have any questions, this is the current recommendation for Moya Moya. Does the surgery works? This is the surgery of this area here is missing blood flow. So we're gonna bring a vessel from outside the brain, put it in contact with the brain and hope that it makes a lot of vessels. This is an MSMDS patient we published in the Regalado paper. And you can see that it makes very little amount of vessels. They have impaired angiogenesis and the patient continues to have more injury. So bottom line, to the literature published, 50-50. 50% of the patients published have a benefit from the surgery. The other 50% have terrible outcomes, including that the strokes becomes larger and larger and larger as they do the surgery. And this is what happened to Rini. This is Rini, 4 months before the surgery, 2 months before the surgery. She had 1 stroke, 2 strokes. The white stuff is a stroke here. And this is what happened after she woke up and she was fine. Out of nowhere, she started stroking and she just moved on the different territories. And if you wonder what her vessels look like, they were very, very affected by the time that she got offered the surgery. Here alone may be the reason why surgery is risky for some people. And that's why we want to study it. We want to say, well, maybe the time to do surgery is now when you have the vessels X and not then when the vessels look differently. And this is a mother, It's called revascularization surgery. We call it EDAS. It's like the least invasive. It's not a bypass. It's just putting the vessel opposed to the brain, the superior temporal artery through a hole in the skull opposed to the brain. In our last, if you go to the A2A website, the 2019, Dr. Ed Smith explained the surgery. And in fact, he had a video of the surgery as well. It's the most common one done for Moya Moya disease. Angela Cass took the lead and mapped every single patient she could get through publications, social media that has ever had the surgery. And we are now connected with every single neurosurgeon that has been involved in these patients and trying to get the medical records and what they're doing. And then in parallel, Angela has asked the parents of those to how did the surgery go? So we have the patient's perspective and the clinician's perspective, and hopefully soon we'll have some more to say about this. Somehow my PowerPoint stopped. Going back to the connections, and I think we are kind of over time, no? Just a little bit. Dr. Rizzo, are you still here? Are you taking responsibility for my classic horrendous time management? You can't mark. There's. It's all right. All right, I'll go really fast. So just to say something, guys, and you heard this, and I heard you that you heard this. The white matter is not all of the sudden there. It develops after we're born. This is 1 month, 2 months, 3, 6 months, and you can see the white matter in white here that is myelinated. The connections are there, but they're getting insulated, and they need to get insulated to get fast. That's why you have the 1 month old, a 2 month old cannot totally train, because the nerves that control the sphincters need to get myelinated and fast to be able to control the sphincters. And this is what happens in a 9 month old. Almost everything is myelinated, but just to give you an idea how the system works, you go all the way to 27 years of age. So that's where teenagers and young adults will justify having poor judgment. The last part to myelinate is the frontal lobe and the judgment, right? And this can be seen in MRI, and then you can see all these particular characteristics. This is a classic white matter injury that the kids and the adults that we met with MSMDS have in their brains. Is central in the white matter. This is the appearance of a stroke. This is the scar of one of the arterial ischemic strokes. You see the cortex is being affected. Here is just the white matter being affected. When we look at those babies that we have images of when they were very young, you see 10 days here, we saw that the pattern of the white matter injury was acute. It was happening right then and is matching pretty well whatever happened years later. Moreover, we mapped it over time, and this is very different to arterial stroke, which is what we were showing before. And when we map this over time, we learned that is not progressive. You see the flat lines? The amount of white matter injury is not going up over time. To me, excellent news, because if we can prevent hypotension, dehydration, we cannot prevent surgery, but we can prepare for surgery differently. We can do anesthesia differently. We probably can protect them from further white matter injury. When is it happening? I think birth is a really tough time for these kids, okay? It doesn't matter if it's C-section or vaginal. It's the fact of having to breathe with your own lungs. And moreover, they're getting these large surgeries for these large PDAs and aortopulmonary windows. There is a lot of risk right then. But I have several patients, we have MRIs before that surgery, the injury is already there. So I want to take the responsibility and the fear of the surgical procedure a little bit away, because we have also evidence that this is happening right after birth without surgery. Hypoxia from the shunting could be contributing for sure. This is probably the most important part of the talk, which is what do we do with it? And that's, to me, is my passion. And that's why we also created, with Mara Yeo, who's sitting over there, educational series for patients and led by families and different therapists. Dr. Wisher is the director of the program as well, sitting over there. We need neuropsychological testing in these kids. A lot of the things that I told you about the network that are affected by the white matter are subtle enough that I cannot see them in clinic on a neurological exam, okay? And why? Because that changes what you're doing in school, the way that you teach, the way that you supplement the therapies, OT, PT, speech. We treat behavioral issues when it's necessary, but remember that the behavioral issues is probably a lot of this network being overused and fatigue. So sometimes the solution is breaks and naps and let them drive the intensity and the duration of their activities. These, we talked about it, auditory and visual processing, I'm 100% sure are affected because the connections that go to those areas of the brain are affected in most patients. And then there's these tiny, small strokes that can happen that also we saw in the white matter. And that's why we also do antiplatelet. That's the aspirin, the Plavix, if they don't have any bleeding. And then the ophthalmological complications, I'll leave Dr. Rizzo for that part. A shout out for an event that is coming up here for those that are in Boston in a couple of weeks. We call it Play to Thrive, and we bring every patient that we know that has brain injury has been participating. There were more than 90 last time, and we do it at the rehab building, which is right next to the water, very nice, and hopefully we get good weather. And you have the QR code. And most importantly, these educational series have now 4 years in the going. And there is a lot of webinars you can watch on YouTube to learn more about auditory processing and central processing, bracing, hypotonia. These are the monitoring recommendations. So get a neurologist, get a physiatrist, get a neuropsych testing, get the hearing evaluation, if possible, central auditory processing evaluation too. Neuro-ophthalmology should be involved, and we'll hear why. Establish contact with the vascular neurosurgeon with expertise in Moya Moya, I think is important. And then only treat seizures if they are there. And then what do we do with imaging? I say you need a baseline. If the kid needs anesthesia, try to do it with very experienced anesthesiologists and put them in contact with the MSMDS experienced person, because they can modify what they're doing to minimize the risk of stroke. So while we are acquiring information and looking at what the vessels look like, we're not giving them strokes. More than a third of the strokes in this population happen when they're going to get scanned. So I don't want to hear about this ever again. So we're going to work really hard. Transcranial Dopplers could be used to monitor the vessels in the brain. And then we don't use catheter angiograms. Another QR code, if you want to go to those educational series, is another part of this organization, nonprofit, that is to get things done that the kids need now, which is advice on how to navigate the journey. This is repeated. You guys know best. I think, Rebecca, you said it. If it's about me, with me, something like that. I had to be there. So please keep helping us understand. And I want to shout out to the people in my lab. These are the collaborators, and each of them is a laboratory in different institutions. You have UMass, Hopkins, NIH, the Brigham, MIT, and then a bunch of people here at MGH. And there is support from someone affected with a vascular genetic disorder that has decided to do its own little startup to help us develop therapies. This is what they look like on Monday. We had the first year of review, and for the people in my lab, if you are here, could you guys stand up? Clinical and preclinical research. Thank you.